KU, Dr. Archie Heddings. We have a short kind of presentation for you, and then that shouldn't take even half the time, and then we can open it up to questions. Okay, so Dr. Heddings, could you introduce yourself, maybe give us some background on how you became who you are?
Hi, my name is Archie Heddings. I am an orthopedic trauma surgeon here at the University of Kansas Health System. And I started out right here at this medical school. I did my residency in orthopedic surgery here. I then did a trauma fellowship at Hennepin County Medical Center up in the Twin Cities, St. Paul area, St. Paul, Minneapolis. And then I came back here and I just started my practice. Started my practice in 2007, and I've been in practice here since then. This is the only job I've had. So.
And then I'll have Dr. Kinda introduce himself. We'll go into more detail on who Dr. Kinda is, but I'll have him introduce himself and where he's from.
Okay, thank you. Sorry for coming late. I didn't know my way to here. Okay, I'm Dr. Patrick Kinda. I'm orthopedic surgeon from Zambia. I hope everyone has got the idea where is Zambia. It's in Africa. Yes, I've been here since May. Actually, my presence here is I'm doing a fellowship in orthopedic trauma. As I don't know if I need to give all the details now.
We'll go into it. Yeah, we'll go.
Okay. Thank you.
Okay, so the first kind of question I have is, for both of you, why you went into orthopedic trauma. Obviously there's many different fellowships you can take, but why was it orthopedic trauma?
So part of it comes down to personal experience. What got me into medicine was I started out in the Army. I was going to make a career out of the Army, but I got in a motor vehicle accident and sustained some serious injuries. I was life flighted to the University of Kansas Hospital. I was cared for here up on Unit 51, went through the trauma bay. It was a life-changing experience for me. You can't make this up. I was blind at the scene of my car wreck, and then I was life flighted here, and it's the craziest thing. When I got here, I opened my eyes, I could see. So, and it's just, there's something about this place. I knew kind of once my career ended in the military, I had great respect for this institution because I credited it with, saving my life. So I wanted to come back here. I found my way into medicine. And then once I got into medicine, because of my personal experiences, I just identified with trauma patients. And so it was easy. It's easy to treat somebody that you can identify with and you can empathize with. So it was just a natural fit for me. And then in addition to that, as I went through medical school, the thing I liked about orthopedics was that you learn how to fix problems. And you'll see this as you go through your medical career and your medical education. There's some things we just don't know how to fix. There's some things we just know how to maybe explain. And that's great for some people. There's physicians that love to do that type of medicine, but I'm somebody who likes to fix things. And so orthopedic trauma is an area in medicine where you can take somebody who has a problem and you can treat it and truly make them better.
Okay, for me, first I didn't have, I've never think that I will do orthopedics and trauma. That was not my idea. I think by the time I was at the School of Medicine, because I did my School of Medicine in DR Congo. Yes, and I was hoping to specialize in public health. That was my dream. But definitely I didn't have a spot. There was no spot for me because the number was enough. And that's why the best option was remaining for me was to do orthopedics. That's why I find myself in orthopedics. But I was, even when I started...
So it wasn't your first choice?
It wasn't.
Okay, all right.
It wasn't. And it just when I went there, then I started, I liked it too much because I couldn't imagine whatever we are doing right now. I couldn't imagine that's what I'm going to find in orthopedics. And my teachers, they like me too much. I didn't know why they like me.
Yeah.
Yes. According to me, I was doing amazing there, and that way I got through and everything. And from the DR Congo, I went to Zambia, and in Zambia, that's a place where I really practice orthopedics because I've been working there with the most powerful orthopedic surgeon in the whole Zambia, with Professor Mula, and for the last 9 years, I've been working with him, and definitely this job is amazing. And it's in Zambia, then I met Dr. Heddings.
Okay, so just as a brief overview of orthopedic trauma, what does like a daily basis look like as an orthopedic trauma surgeon? How often are you on call? Do you see emergencies? Do you also see non-emergencies?
So what orthopedic trauma does is we basically take care of the skeletal frame. And so you'll see orthopedic trauma surgeons usually at a trauma center, and we're part of a team. So if you're somebody that likes working on a team, orthopedic trauma is great for you. We work with neurosurgeons, we work with general trauma surgeons, we work with urologists. It's a whole team. And basically what we have is we have patients coming in who've sustained very significant trauma, mostly blunt here, like motor vehicle accidents or falls, but also some penetrating trauma, such as knife wounds or gunshot wounds. But what we're doing is we're reconstructing a human body that has somehow been torn apart. And you can think of the orthopedic trauma surgeons as the carpenters, and we're the ones that are basically reconstructing the skeletal frame. We do treat people on an outpatient basis. There are certain types of injuries, certain types of fractures that have not just the physical effect of deformity and affecting function, but also a physiologic effect because it causes bleeding or other issues. And so there are certain types of injuries that require treatment right away. I take call about 10 times a month. When I come in the morning, I just find out when I'm on call that day, I find out what came in overnight, what we have in the operating room, and what needs to be taken care of on an emergent basis. And then we also have the injuries that occur that can be treated on a semi-elective basis. These would be things like ankle fractures, distal fractures involving the arm or upper extremities. And these are things that we reconstruct on more of a scheduled basis. The lifestyle of an orthopedic traumatologist can be pretty taxing. I'm not going to lie. It's been pretty stressful for my family. I will put it out there. It has stressed my family. But medicine can do that in any way. Medicine can just be consuming in general. But if you do any field in medicine where your presence can be demanded immediately, know that that is going to strain your life. But also know there's great reward with that. And I think you have to decide, what you want to take.
Okay, but before, when I was in the government, definitely I was many times on call. And right now, we only do elective cases. But we can also get emergency sometimes. But definitely, all my life is just orthopedics. Because even if I don't take calls, but I'm with patients. Because our hospital is a more preeminent orthopedic hospital in Zambia. That means patients come from all over Zambia to come to our hospital. And because I'm the chief medical officer of that hospital, means I talk with patients all the time. They send X-ray in my phone and everything. I have to discuss with them what we're going to do. And definitely they have to bring the patient all over from the town they are to our hospital. Means orthopedic right now it's what I do all the time. Definitely sometimes maybe by the time I've come here it's like I've taken a little bit of break, but I breathe orthopedic all the time.
Patrick made that sound too simple because you said you do only elective cases, but I want to tell you the elective cases he does are very difficult. Just this week, I had a case of somebody who basically had a hip fracture that had fallen apart and healed in this ridiculous position, and the patient had been like this for about 15 years. This is a rare thing for us to see in America. And I told Patrick, I said, I think you want to see this case. And he said, I do about one of these a week. Yeah, because his elective cases, this is the truth. So if you can imagine this, if you can't get medical care in Zambia, you have a hip fracture and you can't get medical care, non-operative treatment for a hip fracture results in mortality about 67% of the time. So you have some of those people surviving, and those people that are surviving are walking in to see him. And then he has to somehow put it back together after the fact. That is incredibly difficult to do, by the way. So
I have a table on the screen. This is not for anybody to read, but it was a review study in 2020, and it's actually from orthopedic injury from 2013 to 2014. So in that time, there was almost 1.2 million emergency orthopedic surgical procedures in the US at that time. And so I was just wondering if you could talk a little bit about trauma in the US and why it's such a health crisis.
yeah, I was looking at that. So those numbers are just from the United States.
Yes.
It shows, number one, the effects of, I think, of our aging population. And these numbers are going to get worse. If you look, there's a lot of falls on there. Those are primarily work-related, but they're also older people. So as our population ages, everybody here is going to be taking care of older people who fall and sustain hip fractures and pelvic fractures. And like I said, if those aren't treated surgically, take a hip fracture, non-operative treatment of a hip fracture, 67% mortality rate. That's in America. So these patients, and if you treat them right, a lot of these fractures, 95% of them at a year, those that have survived, that are without pain and they're functioning well. So you can take somebody who sustains a hip fracture, and if you treat them appropriately, they can get back to living a very productive life. And it's a rewarding thing for them, their families. It's good work. Transportation, that's motor vehicle accidents. I keep thinking that number will go down because my thoughts were, well, we're getting these self-driving cars, it's going to be more safe. But then at the same time, it seems like mental health crises are on the increase and people find a way to overcome the safety mechanisms that are put in cars. So as our society continues to act more, I don't know how to describe it, but as we, in some respects, have more psychiatric issues, we overcome a lot of these safety mechanisms that are worked into our transportation network. So, yeah, machinery, all these things play into orthopedic trauma. So I would say, in terms of my practice, over the years, in some respects, the nature of the trauma that I've treated has changed. It's gone to an older population, and it's gone to a more high energy population. So now when I get a motor vehicle accident, it's not maybe the motor vehicle accidents that occurred because, we had a 2-lane highway that could have, and you have people that just, you have a head-on collision that way, but this is what we're seeing, somebody trying to commit suicide and they're driving as fast as they can and they plow into somebody. So we're seeing more of that type of thing. So yeah, it's not going away. And, if you treat it appropriately, you can save and change people's lives.
Okay, in Zambia, actually, the cause of trauma right now is development. Because some years back, we just have some tiny roads, and especially when you go in more rural area, we didn't have enough road there. But right now we have got wide, nice roads, and most of the young people are driving right now, and definitely those means younger population are actually more involved in trauma, especially when we reach the weekend, like Friday, Saturday, Sunday. Then I expect that either during the weekends, my theater list doesn't move the way it was planned, because there are all the time patients who are coming in, and the Zambian population also, you find more young people. Those are the ones drinking a lot and everything. Then those are the cause of trauma we have in Zambia.
What's the average age of Zambia? Average age?
Average is 15 to 49.
Yeah, I was looking at a statistic, because I was just checking before we came here. It wasn't Zambia, but Africa's the youngest continent and the average age was 20.
Yeah.
So if you can imagine, that's who's driving on the roads. Yeah, that right there just tells you that's going to create a lot of road trauma.
Yeah, and actually, because when you have those tiny roads, that you know that there are too much traffic on the road, then the accidents are less. But right now, I can tell you that when you go by the police station in the weekend to see how many cars, because that's why they bring first all those cars have been involved in the accident. There are quite many right now, definitely. Yeah.
So kind of using that as our jumping point, we'll go into some of the research that you're doing in the African Trauma Initiative. So the first question would be, what is the African Trauma Initiative and why did you create it?
So it's really interesting. There's so many layers to that, Laura. I wanted to do international health, and when I first started my career in 2007, I tried to get involved in it, but I didn't have a way to. I just couldn't find a way, and it's probably good I didn't because I needed to just develop my surgical skills. But after I'd been in practice for a while, I was asked to travel to Romania to help a surgeon there who was trying to do pelvic and acetabular trauma surgery. And that was my first foray into doing international medicine. And at that point, the way most people understood international medicine being performed was teams of medical teams, like in our case, surgical teams would be put together from America or Europe, and they would travel to a low or middle income country. They would bring their equipment, they would go in, they would operate, and then they would leave. And here's what I saw. So we traveled to Romania, and we were at an adult and a children's hospital, and the surgical team went in the adult's hospital, and they offended the people in the adult hospital so much that they got kicked out. That is no joke. And then in the children's hospital, they were accepted. That went a little bit better. But then but all of the surgeons that were working at that children's hospital left. And they said, and I was told that they left was because they felt just demeaned by the American surgeons being there, because nobody, if the American surgeons were around, all the patients that came in just wanted to hear what the American surgeons had to say, and they saw the other surgeons as less than. It was not a good working relationship. Now, I was at the adult hospital and actually made friends with the chief surgeon there. So he let me stay and I worked with him. And what I did was I worked with him for about a week, and I didn't teach him one thing. I just learned from him. I learned what tools he had, which weren't many. I learned what equipment in which he had, which wasn't much at all. And then at the end of the week, an acetabular fracture came in. And fortunately, the time that I had spent there, I knew what tools he had, and I was able to kind of construct in my mind how we would do this surgery. And it went really well. But what I learned from that was, this concept of traveling to another nation and doing surgeries and then leaving, probably not the best way to provide care. And then, the other thing I saw while I was there was complications from a year earlier, where we had operated on somebody, not me, but our team had operated on somebody. They had a complication, and they didn't get any care while we were gone, none. So it didn't seem like the best model, truthfully. And so with that surgeon in Romania, we developed a plan where he would come train with me and in the States and saw what resources I had, and then see what he could get back at his hospital, and then apply the concepts that we were doing here in America with the resources he had. That worked very well. I was asked to go to Ethiopia, and when I did, we tried to do that concept, but the problem was their resources were so scant compared to what was available in Romania. They needed much more in terms of resources, and they needed much more in terms of training. So what we did was we came up with a year-long fellowship. So we brought over, you'll see up on the board, Dr. Abbey, who's got his hand in the air, and Dr. Solomon. Very accomplished surgeons, incredibly accomplished surgeons. But what they lack is, they lack the hospitals, just the number of hospitals, and they lack the equipment to do state-of-the-art trauma care. Brilliant in thinking, but they just lack the resources. So we brought them here to train with us for a year. And as they were working with us, they said, everything we're learning is great. And we're learning how to do everything, by the latest and greatest techniques. But we need to solve this problem in terms of getting us the equipment to do that. So we sat down with a group of medical students, of which Colin, Laura, and Michael, them, they're a part of this. And them with other medical students from KU, came up with this plan to raise money to try and get them these things. And it's grown into paying for fellowships to train the surgeons how to actually perform the surgery, as well as getting the equipment they need to perform state-of-the-art trauma surgery, and then building them the hard structure they need, like the operating rooms. It's a big task, and believe it or not, it is primarily powered by medical students and undergraduate students. Last year, I think we raised over $30,000, which isn't a lot. We got a long way to go. But that's what birthed this, and it really wasn't me. I don't think it was me that started this, Laura. It was like a conversation we had one day at Dagwoods, and we were all talking about how to solve this. And it was all of us together putting our minds together. And that's what started this. And so that's what you're seeing here is our effort to make a dent in the trauma epidemic that's ravaging Africa right now. Because it's like Patrick said, it's when I went there and I just saw the overwhelming amount of trauma, anytime there's a problem, you try and get a diagnosis. It's like, what is this? Why are there people just lined up outside of the hospital with trauma? And why are we sending home people with fatal injuries? Why are we doing this? What's the diagnosis here? And the diagnosis is, as Patrick said it, it's, how'd you put it? Industrialization, rapid industrialization.
Yeah.
Rapid,
Yeah.
chaotic industrialization. And I'll let you speak to this, but from what we found out is, this is what's going on. Africa is rich in natural resources, and it's rich in human resources. As I said, it's the youngest continent. It has the cheapest labor on earth, so the cheapest labor in human terms. And then if you just take the Congo, I think the Congo has like 90% of the world's chromium. It's rich in copper. And so that has made this Africa this ring in which the world's largest economic powers are competing for global dominance. And they need those natural resources to power old industries and frontier industries, and then they need that human capacity as well. So it's resulted in massive buildup of road networks, and then all of this other industry that's being built up in terms of mining and things like that, and it's contributed to all this trauma that we're seeing: road traffic accidents, conflict-related violence, and then all the accidents that occur at these jobs, because a lot of these jobs are performed in very unsafe environments. Do you want to say anything about that?
Okay, I think Dr. Heddings have said almost everything. But as he was saying here, that I will just give you an example. I remember there some years back, just by the time the total hip replacement surgery was introduced in Zambia, means at the time we started to practice the primary total hip replacement, but we didn't have implant for revision. Means when you have a problem, how do you revise this hip? We didn't have it in Zambia. But as a day we're doing the surgery, just by as we're trying to reduce our hip to finish, and the patient sustained a fracture on the femur, which actually required special implant, which we didn't have. And but the surgery was done, and that patient after because she was walking before coming to theater, and after doing that surgery, can you imagine if she can't walk? I don't want to tell you what we did, but the patient is fine right now, And that's a main issue. Means you can have your operating room as you have here, but if it's not a well-standard operating room, then you can't do anything. If you don't have, you can even have enough equipment, but if you're not acquainted how to use those equipment, you can't do anything. We have some orthopedic surgeon, good orthopedic surgeon in Zambia, but in hospital where they are, like in a government hospital, there is no traction table. There are no CM. CM is the X-ray what we use in theater. But when you're an orthopedic surgeon, but you don't have a CM, then you're stuck because you can't do anything. And when you don't have X-ray, those are the problem we have. A lot of hospitals, they don't have X-ray, but how are you going to diagnose a fracture without an X-ray? And myself, most of the surgery we do, I just rely on X-ray. We don't use CT scan like it is here because it's quite expensive to use a CT scan. Means when Dr. Heddings is reading a CT scan, he can just take a few seconds to see what is there, but it will take me a while to read that. That's because I'm not used to CT scan. We do CT scan maybe if I have a spine fracture and you have acetabulum fracture, then, but all these fractures mean we don't use a CT scan. Means the main things here is first, if you don't have good equipment and if yourself you are not trained to use those equipment, you can't do anything. We have, in our hospital, we have a CM, which is hold one, and it's the only one remaining. If that one is down, then we are stuck. And now the problem there is that the hospital needs to buy another one. But when is the hospital sustaining itself? You have to pay salary for the workers. You have to pay insurances and everything. And to just fundraising money to buy an MRI, a CT scan in the hospital is not easy. And to get this training, as I was saying, we've got good orthopedic surgeons, but most of them they've never used a traction table. We have a traction table in our hospital, but they are more senior than me who comes in my hospital, and I have to teach them how to reduce a fracture with a traction table. That's the main issue. I mean, we need good equipment, we need good training, and that's why I'm here right now, because the time I was discussing with Dr. Heddings, we're actually talking about acetabulum fracture, because we get the same type of acetabulum fracture which we have here, but there's only one surgeon who does that surgery, and he does only one type of acetabulum fracture. And the majority of those patients who goes through those surgery, they usually come back for a revision, because and myself, there's a time I would even think that all the acetabulum fracture we need just to revise them. And that's why I was having that discussion with Dr. Heddings. Then I said, okay, we need to come here to go through all different types of acetabulum fracture. And when I came here, I see what he was doing in theater. That was amazing, because I've never seen a nice reduction, a nice treatment of acetabulum fracture than what I've seen, what is done here. That's why I'm here.
You know, I think it's really interesting. And Laura asked, why did we start this African Trauma Initiative? I want to talk about it a little bit more, because it's kind of hard to wrap your head around it. Because I remember sitting in your shoes, and it seems like so much of medical school is spent on learning how to manage medical disease. But so you said there's only one person in Zambia who does pelvic and acetabular surgery. Only one.
Only one.
And you're going to go back and not only work in Zambia, but the Congo. How many in the Congo do you have?
Okay, that's what I forgot to mention. Actually, in Congo, you can't do that operation. Though the country is very rich, there are a lot of companies that are doing a lot of things, but the medical system is poor, is down. Yes.
So, medical disease and surgical disease. Trauma is a surgical disease, okay? Let's take as an example HIV. That's a medical disease, right? And I think most people know of how HIV was ravaging Africa, right? And it was back in the Bush era that America gave a lot of money to Africa to help combat the HIV epidemic. In Zambia, when I was there, it was interesting. I think the numbers were 1 out of 3 people died of HIV in Zambia. 1 out of 3. It's hard to fathom that. That's how many people died of HIV. And when I was there was a billboard that said, "Thank you, America." They were that appreciative of what we had given to help them overcome that epidemic. But if you give the right medications, you can save a lot of lives. And it's a good example of how medical disease was treated really well. But the way things are now is actually trauma kills more people in Africa than HIV does. Even if you add in HIV and tuberculosis and malaria, trauma is killing more people now. So it's hard to wrap your head around that. In some respects, it's good. Our medical treatment has worked. But what's really the big epidemic right now is trauma, and that's just the people that are dying of it. Add to that those that are disabled from it. So take a simple thing like an ankle fracture dislocation. It could be treated by an outpatient surgery here in the United States. The person gets back to doing everything they did before. But if it's not treated appropriately, that person cannot get back. They can't get back to their previous activity level. They can't get their job back. They're now a beggar. Their children may be beggars. Or they could end up in prostitution. All for a simple problem that could have been solved by an outpatient surgery. So, yeah, so there's this surgical disease, and it's really large, and it's killing and disabling lots of people. And it doesn't just affect the people who sustain the injury, but it affects all those that depend upon that person. How do we make a dent in that epidemic? And basically, the African Trauma Initiative is the University of Kansas attempt to try and make a dent in that by training people to treat orthopedic trauma.